Hello, and welcome to the Physical Therapy Owners Club podcast. I'm your host, Nathan Shields, and today I'm bringing on the primary PT for a 24-bed ICU in Central Oregon, Andy Sabatier, who I met under odd circumstances, but we'll get to that later. But he is also the founder of Academy West Breathing and Performance in Central Oregon. And I wanted to bring Andy on because he has a unique perspective. As a physical therapist in ICU, he has seen the whole course of COVID-19 coronavirus pandemic in patients that have come through the hospital, and they are currently gearing up. Well, they've seen the patients, they're also gearing up for more. So first of all, Andy, thanks for coming on and joining me with the podcast.
Happy to be here. Thanks for having me, Nathan.
Hey, you've seen it all from what I could tell so far as the course of the coronavirus and the patients that you're dealing with in the ICU. If you could just share with us from your PT perspective and dealing with some of these patients, what does that course look like? I think there's a lot of unknowing out there of what this looks like, what patients are feeling, what they're going through, what that course looks like. So could you share with us from your perspective what people are dealing with in the ICUs?
Sure. So the word you used, unknown, is very accurate. Every day we're dealing with a new reality. We have been, from a rehab standpoint, trying to kind of understand where does physical therapy enter that patient's care, whether they're critically ill or mildly ill or somewhere in between, on that spectrum of disease process. But every day is a little bit different. To say that I've kind of seen the whole course, I've seen how the course of the disease goes with the sickest people. Okay. We have only a little bit of knowledge to go off of, and I'm trying to consume as much data as I can from the CDC and the WHO websites, and trying to read up on the data that's now coming out of China and coming out of Italy and coming out of Australia even. But there seems to be a theme where things move really fast. People's incubation is anywhere between 2 and 14 days. Most people, it's about 4 or 5 days. Once that disease has progressed to the point that they have to come to the hospital because of increased oxygen needs, low SpO2 values, we're seeing a rapid progression. So
what are the symptoms in those cases? What would a layman feel in that situation?
The most common symptoms with COVID-19 appear to be fever, cough, shortness of breath with some patients. Most are experiencing a myalgia, but the two main symptoms that people are having are that dry cough and a fever.
And the myalgia is simply the body ache?
It's a body ache, and there's also an element of fatigue, just marked fatigue, where people are just far more tired than they're used to being, and it lasts day after day after day.
Okay.
That being said, there are also some people that's the whole disease, and then they get better. Those are the people that are at home just kind of waiting this out, hoping that everything's okay. But if it does progress, and there is a respiratory element, pretty fast, because all of a sudden it's getting harder to breathe.
Yeah.
As people need increasing amounts of oxygen, the speed at which the disease moves is fast.
Really?
We've had a couple of people that come down to the ICU and are quickly intubated, and things progress fast from there. Normal course, if we're talking about the most critical patients, those patients are going to be intubated, working on a mechanical ventilator. Depending on the amount of support they need, their bodies may be working really hard, which is counteracting how much they're trying to get air in, because they're working too hard and it's kind of wearing them out. When somebody's working so hard that they're wearing themselves out and they're very anxious, there's lots of drugs that are used to kind of slow the body down, and even to the point that they'll paralyze.
Oh, really?
If somebody is paralyzed, medically paralyzed, to give their body a rest. The position of the body has a lot to do with how they want the lungs to drain, or how they want the lungs to get rid of all the fluid and mucus and consolidations that are built up.
Well, really quick, Andy, can I just jump in really quick?
Absolutely.
So those people that are progressing really quickly, do they usually have other underlying medical conditions? Are they a certain age group, or are you seeing healthy people regress that quickly?
Mostly it's people with cardiac conditions, diabetes, chronic lung issues, liver conditions, kidney issues.
All right.
All of those chronic problems get exacerbated. One of the things that's not necessarily being thrown out there quite as much with COVID-19 is that there is a cardiac element to it. There appears to be kind of a COVID-19 cardiomyopathy that happens where
Oh,
all of a
really?
sudden their ejection fraction is just poor. Somebody
Really?
who's got a functioning heart, or at least a fairly well functioning heart, will all of a sudden their heart will just not be working nearly as well.
Mm.
So
And these are
when
people
all
that
those
have had
body
cardiac
systems,
conditions before?
some yes, some no,
Okay.
mostly yes.
Okay.
But when all those body systems start shutting down at the same time, it's really just a matter of, okay, let's get everything to calm down.
Yeah.
Let's save this person's life. Let's make sure that all those systems recover before we start doing anything else. And that usually involves, at least so far, we've had a lot of patients that we position prone. So
On their stomachs?
we'll have the person laying in bed, and then we'll flip them over so that they're facing downward, and their lungs are then allowed to drain a little more easily. The
Mm.
worst position the human body can be in to breathe is laying flat on your back.
Really?
You know, there's something that I often say to my patients when I'm going in and meeting them and introducing, why is a physical therapist coming to see you in the ICU on the worst day you've ever had? And it's basically because there are really only three things you do laying down. We sleep, we have sex, and we die. We're
Mm.
here to do none of those things. So it's time to get you out of bed.
Yeah.
And that usually gets a laugh on, hopefully, what's one of the worst days
Yeah.
they've ever had. But
So is it a good idea if you are if someone's maybe recovering at home, or maybe they are in the ICU wing of the hospital, is to get up and sit up for quite a bit of time and walk around a little bit?
absolutely. So in general, in life, the bed is the enemy.
Okay.
There is nothing good that's going to come from inactivity.
Okay.
Even if you are in some sort of disease process, unless you're so far advanced that you can't maintain your breathing
Yeah.
without help,
Hmm.
you should be moving.
Yeah. Okay.
Not saying you should be out running laps when you're sick, but standing up, marching in place, walking around your house,
Okay.
making sure that you're continuing to move is going to allow your body to get some of those secretions out. It's going to allow you to kind of move that venous blood back into the center of your body, move all that lymph system. Everything should be moving along with your body.
Yeah.
So when we sit still, only bad things really happen.
I gotcha. So even if people are recovering from home, they should at least get out of the bed, sit up, move around, walk, get some fresh air, I'm assuming, as well, like they're
Absolutely.
recommending. You might be able to do that with some of the people in the ICU, but when it gets to the point where they need ventilation, that's because their body, what's happening at that point that they need ventilation? They're just not getting enough oxygen into their body?
So I don't want to tread too far into somebody else's area, because I will do a worse job of explaining medically why things are shutting down
Okay.
than their intensivist or their pulmonologist. But the way that I try to explain it to patients, before this COVID crisis, when we did have family members that were in the room and they're wondering why things are going so badly, there are a lot of muscles that have to work in conjunction to accomplish normal breathing.
Mm.
When your lung tissue is suboptimal, when it's stiffer, or when it's clogged with mucus and consolidations and fluid,
I could,
or any number of reasons that can cause you to
yeah.
have respiratory failure.
Yeah.
It's a matter of trying to support the body through that. Most people don't have an understanding of what muscles they're using when they breathe, because
Mm.
they breathe without thinking.
Yeah.
And oftentimes are working really hard to breathe, but
Mhm.
not necessarily working smartly, if that
Yeah.
makes sense.
Yeah, and this is the reason why I wanted to bring you on today, is because you essentially teach breathing every day. That's part of your job. You're teaching all kinds of patients how to breathe properly, and so doing some strengthening for the breathing musculature. We know it's the diaphragm, but doing exercises for your breathing can improve your uh, your ability to overcome and recover from this flu epidemic, right? And you're seeing that as part of the process in the ICU.
Definitely. So I'll only slightly correct you, and then I'm sure we'll
Please.
kind of come back to it.
Cool.
You're right. The diaphragm is the primary muscle of breathing, but the muscles that accomplish your breathing, it's a concert of muscles.
Sure.
Everything
Yeah.
from starting with your mouth, orbicularis, glottal folds, into the intercostal muscles, down through the diaphragm, TA across the front, quadratus lumborum in the back, pelvic floor on the bottom. Those are, PTs talk about core muscles. Guess what? Those are your core muscles.
Core
All of
breathing
those that I
muscles,
just said.
right?
Those are just your core muscles, period.
Period, but also your core breathing
Period.
muscles.
Exactly. Yeah. And like, what's more core activity than breathing? So,
Yeah.
uh, usually what we're trying to do is we're trying to train a little bit of every one of those. Maybe not the pelvic floor in the ICU setting, but we're teaching people how to use their mouth effectively. We're teaching people how to use their glottal folds effectively for coughing and versus huffing. We're teaching people how to expand their chest. We're teaching people how to recruit their diaphragm. Now, the diaphragm is definitely the most important thing, because if that diaphragm isn't working efficiently and effectively, there is very little chance of being able to take the kind of breath that you need to take in order to recover and clear your lungs and
Really?
and recruit enough oxygen to your body that you can function.
Gotcha.
Yeah, definitely.
So what does poor breathing look like compared to good breathing?
Okay. So poor breathing. When we're assessing breathing, we have to look at two things. We've got to look at their sequence and their pattern. The number one pattern that I see with most people, the poor breathers, are this. Anybody that's using those accessory muscles, all you have to do is ask somebody, please take a deep breath, and you'll know right away. You'll see what they do. You'll see what muscles move the most.
Yeah.
And our traps are one of those muscles that kind of takes over. It's a big bully group.
Yeah.
Big, massive muscle, directly innervated into the brain through cranial nerves, right? Not a spinal nerve at all. It's one of the first muscles that forms in our neural tube when we're in development. And if you let it take over, it will take over anything, whether that's some physical movement like that you'd see in an outpatient orthopedic setting,
Sure.
or somebody who's relying on it for breathing. But
Okay.
it's a muscle that's designed to keep you alive, right? It's fight or flight. If you hear a bear behind you, your shoulders come up and you're running away from them, right?
Yeah.
Or if you hurt yourself, you stub your toe on the corner of the bed, you go, that hurt, and your shoulders come up. The second you get anxious or worried, your shoulders start coming up. Anybody that's painful is coming up. So it's one of these muscles that all those things that wreck your breathing are linked to your traps. So everything we're trying to do when it comes to patients with difficulty breathing is get them to calm down the accessory muscles, recruit the diaphragm, because it's the complete opposite of the traps. Traps are designed to move your head. They're not designed to move 20,000 times a day, which is about how many times you breathe, somewhere between 17 and 30,000 times a day. Your diaphragm, on the other hand, is designed to do exactly that. It's a slow twitch muscle. It moves in big, slow arcs up and down. And if you can train it, it'll just kind of support your breathing without you even really trying. The most efficient and effective muscle in our bodies. It's actually the second most important muscle in anybody's body, but we don't talk about it at all.
Yeah.
Right? That's one of those easy things. You walk in, you say, okay, we fixed your heart. Now let's talk about the second most important muscle you've got, and it's right here, and they don't even know where it is.
Yeah. So a good breath is not this, but what does a good diaphragmatic breath look like?
Okay, so I'm going to slightly tilt you down because I'm a hand talker. All right, so when you're assessing somebody's breathing, you should be able to see SCM, scalenes, traps, intercostals, right down here. You're going to want patients to follow their sternum down, find that spot right where the xiphoid process is, that soft spot. That's where your diaphragm is, and then tell them to sniff in. If you sniff with a quick little sniff, you should feel a quick impulse of that diaphragm. So if you're not getting that right away, you've already identified somebody who probably is sequencing like this. They're going to go up. All that results in is ineffective breathing. So coaching them through that, helping them understand, okay, this is where your diaphragm is. Feel it, understand it, touch it. Because you have one, you have to learn how to use it. From there, a smooth, natural diaphragm contraction is going to pull.
Yeah, pull down again. There we go.
Right? We're going to have expansion in the lower fields. There's a little subtle expansion forward, lateral expansion of the lower ribs, mid-thoracic, just a little bit of expansion, slight expansion upward. But you'll see I'm tilting my hands because that's the action of the ribs. They're like bucket handles. They just tilt up. So as you inhale, diaphragm comes out and then tilts up. And never at any point am I raising my shoulders or using any of these neck muscles to. Now, if you get somebody to maximally inhale, I mean, it can be anybody, whether it's an athlete or just a layperson. The biggest breath you can possibly take is at the very end going to recruit some of these muscles. But these aren't actually accomplishing any of that expansion of the thoracic cage. They're just kind of finishing the job.
Well,
So
when you're talking about sequencing, that's the last part of the sequence, I'd assume.
yeah,
Very last part.
normal sequencing goes diaphragm, lateral expansion, upper chest expansion, and nothing else, nothing above where my hands are here. So if you're getting any movement above the shoulders, that's more accessory muscle recruitment than you want during even, normal quiet breathing or exerted breathing.
So you're training this on every patient if they've got a respiratory issue in your hospital, I assume.
I think I'm training this on every patient.
Pretty much, right?
I mean, I used to. It's funny when I started going down this kind of wormhole a couple of years ago. Initially, I was sort of going, "Oh my God, am I going to be able to do this with any of my patients besides these hearts, or if somebody's got a pneumonia?" And then the more you see it, every single person breathes.
Mm-hmm.
Not every person breathes well.
Yeah.
But strokes
mm-hmm.
definitely have breathing problems. Kidney patients, tons of breathing problems. Anybody with any neurologic compromise, breathing problems. TBIs, breathing problems. You name it. And the more I started doing it, the more I realized if you can optimize anybody's breathing right before they move, you're going to get more function out of them.
Mm-hmm.
It's almost like giving somebody like a supplement before they work out. Like, have this shake, and it's going to like allow you to work out a little bit harder and get a little bit better lift in and get more results. It's the same exact thing. If you can breathe better, you're going to be able to walk farther. You're going to be able to do more tasks. You're going to be able to accomplish more. My mentor has a very famous phrase. Mary Massery says, "If you can't breathe, you can't function." And she is 100% right. All the things that fall under function, you got to be able to breathe.
So what are some of the exercises that you're giving some of your patients, or what anyone who's listening say? What are there some exercises that you can share with us that you take people through if they're feeling some of these issues, or even if they want to just breathe better in general? What are some basic exercises they can do?
So basic exercises for anybody to be able to do. That one we just talked about where you identify your diaphragm. The first thing you got to be able to do is find it. Once you find where your diaphragm is and feel like you can breathe, I don't want to say breathe to it, but breathe using it every time, training yourself on the in the nose, out the mouth breath where you feel a big expansion right here. And getting comfortable with that. Okay. I usually will try to pair that with some other visual input. Okay. One of the reasons why we don't breathe or we don't understand the way we breathe is because we don't see it. I know how my arm moves because I can see it, right? I understand the elbow, I understand my wrist. If my fingers aren't moving right, I can tell because I can see them. Okay. I have no idea what's going on here, and ignorance is bliss. So I just go about my life. But if you can get yourself in a situation where you can see yourself breathe, that's going to help. So I tell all my patients, okay, tonight when you go home and brush your teeth, I want you to stand at the sink for 1 minute with your shirt off and breathe. That throws some people off, but it's your anatomy and you kind of have to understand how to use it. Nobody's there watching you. Yep. So spend a minute watching yourself breathe, understand what moves and understand what doesn't move. Given the knowledge that we just went through, right? We just talked about, okay, these should move, this shouldn't move, and you want motion here and you want motion here. You don't have to get into all the anatomy. You just have to kind of show them where things are. Yeah. Once you have that, that starts to change how you think. Most of what changes breathing is just thinking about it. Not saying you should be walking around all the time thinking about how you breathe, but it's going to be hard not to think about it if you're understanding more of it and you know how to be more efficient. Sure. Imagine if I said, here's a way for you to walk and save your energy. People be like, yeah, I'll buy into that. Yeah. All it is control your breathing. Like, have a breathing strategy. Be purposeful about what you're doing. So when you've got somebody walking out in the hallways in the hospital, or somebody out training for a run, or somebody that's just trying to motivate themselves to have lower stress levels at work, all of that can be accomplished by having a breathing strategy ready to go. That's based in knowledge. So understanding how to use your tool. And so what I'm gathering from you is, like, if I was at work, or maybe if I got sick, right, I'm going to start thinking about sitting upright and thinking about in through the nose, out through the mouth, but also maybe feeling my stomach, or like you said, looking in the mirror, feeling my stomach expand and contract, feeling my ribs flail out and in or up in front and down, and just concentrating on that. And would you have someone do that a certain number of repetitions if you were essentially in a therapy setting? Sure. Well, in a therapy setting, it's like you're under my control. So I'm gonna be kind of working you, and I'm gonna tell you what to
Lots
do,
of
and I'm gonna sort
cues.
of, yeah, lots of cues, and I'm gonna look for those little things, and I'm gonna use my hands to try to get you to understand where I want you to move things. But for homework, it's it can boil down to being as simple as devote 60 breaths every day to getting better.
Okay.
You take 20,000. You can probably find 60 breaths to make yourself a little stronger and a little better.
Mm,
Maybe that's 30 breaths while you're laying in bed, just trying to focus on how much your diaphragm moves. Maybe that's 30 breaths when you're out walking around, just taking them slow, in through the nose, out through the mouth,
relax the
and
shoulders.
slowing it down, right? But doing
Yeah.
it while you're active and
Sure.
understanding that, I can deep breathe when I'm out taking a walk. I can deep breathe while I'm sitting there typing away. Um, there is literally not a time when you're not breathing
Mm.
unless you're here.
Yeah.
Um, and then
Hopefully
you got
not.
a whole nother
Yeah,
circumstance,
it's
and
a
then you're
different story.
definitely not working with me.
That's right.
But truly, it's changing your perspective on things.
Mm.
If we're talking about a specific exercise to actually strengthen the diaphragm, it's like any other muscle. It wants resistance. There are lots of respiratory trainers out there that you can put in your mouth, and you can kind of breathe in and breathe out, and it'll give you a little resistance. But the best respiratory trainer you have is right here, orbicularis, one of the strongest muscles we've got. Think of what I tell my patients is I want you to purse your lips really tightly, just like we were doing when you were blowing out, like you're blowing out candles. Except this time, what I want you to do is have that hand down on your diaphragm, and you're going to inhale through that same tightly pursed lip mouth. So if I'm here, I'm going to slightly tilt this down. So
Yes.
I've got my fingers on my diaphragm. You can see my mouth, and I'm going to go. So it's the opposite of pursed lip breathing. It's pursed lip inhalation rather than pursed lip
Mm.
exhalation.
Oh,
And
okay.
what I was able to do, because I was breathing slowly and I had a little bit of resistance, is feel the diaphragm completely expand and then gradually moving the air up into the chest and feeling, all right, this is where it stops. This is as much air as I can fit in before I start pulling my shoulders up.
Okay.
It's time to let it out. And then open
Nice.
the mouth and let it out. Relax.
Okay. I love it. Oh my gosh.
Yeah,
And
simple
and
stuff.
and you're seeing some incredible results with your COVID patients, I'm assuming.
I've had the patients that I've worked with, my COVID patients, are the ones that I like to say, like, where is physical therapy entering into their continuum of care? Some
Okay.
people, it's like they're coming into the hospital and they're feeling sick and they're up on the medical floors, and we're helping to just kind of keep them moving and keep them doing things.
Sure.
The patients that I'm encountering are the ones that crash, the ones that come down, that go into multi-system organ failure, go into respiratory failure, are intubated, and then often prone, paralyzed, and after 4 or 5 days, when their lung function starts to recover, then we start weaning them from sedation. So I'm kind of the first person you see
Okay.
when you can move, right? You see
Mm.
your nurse in and out of the room, but the first time you sit up at the edge of the bed is with me.
Okay.
So what I'm doing with those patients is, first we work on your breathing mechanics. We try to make sure that you've got all those things we just talked about.
Hmm.
Once I feel like things are moving in the right direction, with somebody behind you and somebody in front of you, we help you sit up on the edge of the bed. So now you're just sitting up on the edge of the bed for the first couple of minutes, maybe 10, 15 minutes on the edge of the bed. That might be your whole PT session. But
Mm.
through those 15 minutes, we're going to be working on trying to focus on deep breathing, getting your mechanics to be sound, and making sure your breathing is moving in the right direction.
Hmm.
Everything is about nudging the system. Our bodies are designed to breathe really well. It's why none of us have to think about breathing. But when you can't breathe well, we've got to try to do something to nudge your system the other way.
Hmm.
COVID-19 is what wrecked your breathing, or maybe it was all these other complications and comorbidities that you had prior to admission.
Yeah.
But now we need something to push the other direction. So by getting a little bit of a nudge towards sound mechanics, we see people start to improve.
Hmm.
Once that improvement's happened, now it's time to do something with it. So for me, I'm thinking two things. Okay, your breathing is improving. Now we want to add a functional task, and we want to change your position.
Okay.
So by giving somebody a functional task, let's say it's reaching or balancing on the edge of the bed or standing up or walking or any of that, making sure their breathing is solid first, and then giving them a functional task to do at the same time. Because you got to be able to walk and chew gum at the same
You
time.
don't have
Sorry
to
about
hit the
that.
floor, do you?
No, that's my occupational therapist coach
Okay.
spouse.
All
She's my
right.
partner in crime, and she's, bless her heart, she's been dealing with me as I've gone from not understanding anything about breathing to preaching the gospel, and she's
There you
bought
go.
in. So I
There you
walk
go.
in the room sometimes, and she's coaching patients on breathing as well
Oh,
with
awesome.
OT tasks. Yeah, it's pretty
That's
cool.
cool. That's cool.
What was I going to say? She threw me off. Either way, that's where we
Yeah,
are.
that's
Oh
awesome.
yeah. So the course of the disease. So with those patients, you know, that's their first PT session. The next day you come in, you're seeing significant changes. They're more alert, they're more awake, their mechanics are better, their oxygen requirements are lower, and
Mhm.
their activity tolerance is much better.
Yeah. Just in
It's almost
24
like
hours.
just in 24 hours, just as fast as the disease can come on, excuse me, as fast as the disease process can accelerate, the recovery process can have equally impressive sort of leaps. At
Mhm.
least that's what I'm seeing so far.
And it can be spurred along as long as they're breathing better, as they're getting deeper breaths and strengthening up the diaphragm and becoming more functional, getting out of the prone and supine positions and sitting at the edge of the bed and walking. Man, it starts coming back really quickly, huh?
Yeah, the bed is the enemy. I mean, anybody's going to get worse in bed. It's
Mm.
the one thing we know. We know that no matter why you're here, this bed is the thing that's ultimately going to take you down.
Mm.
So it's not going to guarantee that you get better, but the whole point of the ICU is to increase the percent chance that you survive.
Yeah.
We increase the percent chance that you survive when you move, when you get out of bed, when you start doing functional tasks. Because along with the physical aspect of it comes the cognitive aspect.
Mm.
People that have been down in the ICU for days, they lose track of day and night. They lose track of life in general because no cues are coming to them saying, you're awake, it's daytime, it's nighttime, it's time to sleep. It's all just one sort of bizarre reality, kind of like the bizarre reality we're living in now as a society.
Yeah.
But we have a way of kind of resetting that. They don't.
Mm.
The PTs and the OTs, we're the ones that are trying to restore function. We're trying to restore something normal. And that normal thing is you got out of bed today.
Yeah.
You took deep breaths and you coughed and you moved and you did all that, but you also stood up. You also sat on a toilet. You also looked in the mirror and brushed your teeth. Those little things help to kind of cue the brain that, all right, we need to start moving along. This is important that we recover, and we play a role in this. One
Well,
of the most
it sounds like you provide hope. Like, hey, I'm
oh,
getting back to normal function. And so you're showing the light at the end of the tunnel.
we hope so. I mean, one of the things I ask all my patients, and I have a lot of one-way conversations because I have a lot of patients that are on ventilators or just can't really talk.
Yeah.
So it becomes kind of a like stand-up comedy. But one of the things I say to them is, "Do you feel like you accomplished something today?" And by and large, they say, "Yeah, that's." And I say, "Remember that, because this place is going to play tricks on you. Your job is to keep it together for the next 23 hours, because the next time I see you, I want you to still be progressing."
Yeah.
And there's so many things that we do for you at the hospital. There are actually, we can do everything for you. We can keep you alive without your brain even being functioning. But
Mm-hmm.
the one thing that I tell patients is your job is to breathe. I can't do that for you. I can
Yeah.
help you, I can show you, and I can help nudge your system along. But these are the exercises that I want you to do. This is your incentive spirometer. This is your acapella. This is diaphragmatic breathing. This is pursed lip breathing. This is how to cough. This is how to huff. This is how to whatever.
Mm.
But this is your job. We've got jobs and you've got a job too. Your job is to breathe.
Mm-hmm. Now tell us really quickly, we're going to wrap up here soon, but how should someone cough if they are having some of those issues?
It's a good question. Everybody's a little bit different.
Okay.
Some people, when they cough, they get into coughing fits and then they can't take a deep breath in. And then that, I would say like 5 mini coughs is not really effective. In fact, coughs are kind of a high risk maneuver if we're talking about pulmonary clearance, right?
Okay. Okay.
Sticky secretions get stuck in the lungs, and a cough is a high pressure move. Closure of the glottis, developing all that pressure using all those muscles we talked about before, and then big cough out. Sometimes that cough can be so much that high pressure reaches a choke point and it pushes the secretions back down.
Ooh.
So sometimes it's preparing yourself to cough, right? Making sure that you've done all the techniques you can to try to loosen all that gunk up before you cough. One of
Okay.
the really simple things we teach people is active cycles of breathing. I mean, that's one of those things we learned in PT school. Like I remember hearing that term, like, oh yeah, active cycles of breathing. I remember that. But it really does work to try to get people taking big, slow, deep breaths and then moving some of those secretions along with a maneuver called a huff. A huff and a cough differ
Okay.
whether or not the glottis is closed. So if a cough looks like this. If this is the glottal folds close and the pressure's built up in you. But a huff, you keep the glottis open in you and try to move things along. And you can sort of have a smaller huff, a medium huff, or a big huff, depending on the airways you're trying to clear. But that's the kind of thing that's guided by somebody who's around you or written down on a piece of paper. So you can say, okay, I want you to follow this step-by-step thing. So that every time you're going to get a big old cough, because it takes a lot of energy, I want you to try to get as much ready as you can so that you're coughing effectively.
So some deep breaths followed by some huffs and then a full-blown cough.
So an active cycle of breathing is 3 to 5 deep breaths all the way in, 2 or 3 second hold, casually relaxed, let it out. It's not like blowing out. So it'd be hold for 2, 3, all the way out. Repeat that 4 or 5 times. Then you're going to start doing huffs where you have little huffs, medium huffs, big huffs. So little huffs, medium huffs, big huffs. And finally, once you feel like you've kind of gotten things going, now you cough. Now you tell them, okay, take that big cough, build up pressure, and then out it comes. I naturally kind of do that thing where I'm a sternotomy patient. I'm holding my cardiac filler, but it just sort of works for me. But
yeah, I gotcha.
You know, a cough can be a double-edged sword because a cough can send you into a coughing spell. And everybody's been there where they're coughing and they can't take a big breath in without agitating their airways. So it's more about, okay, if you're in a coughing fit, we actually want you to slow things down. We want you to breathe in the nose. We want you to breathe out the mouth and slow it all down. How you cue people as a therapist is really, really important. The timbre of your voice. If you want somebody to inhale, you can use big, exciting cues. Inhale, right? But if you're trying to get somebody to exhale calmly, you've got to slow it down. You want their diaphragm involved. That's a slow moving muscle and it's a calm muscle. So what we want is calm language and using your tone of voice to try to get people to do what you want them to do. So your job as an educator kind of turns into something different than you're used to.
Yeah. Interesting. I mean, I love what you shared with us so far because it's about breathing and not only just breathing, but the anatomy behind it, the proper breathing cycle, and huffing and coughing for those people who get to that point where they might have some productivity in their lungs, and how much it can help people to overcome and recover from some of these flu-like symptoms that they have. And it's imperative. I mean, especially considering this is mostly a respiratory issue, that a lot of this information gets out.
And you know, the thing that I'm glad we're talking about all the pulmonary clearance stuff and the mechanical stuff that has to do with breathing, but breathing is the point where your physical body and your mental body, for lack of a better term, collide. You know, somebody who's anxious breathes differently than somebody who's not. We know that for sure. We also know that you can use your breathing to slow your heart rate down, to lower your cortisol levels, to get your body's sympathetic nervous system to calm down and your parasympathetic nervous system to turn on and bring some of that balance that our body is supposed to have. So owning your breathing means owning all those different aspects, owning the, you know, your own role in your anxiety. Everybody's been anxious, and this is a really anxious time, but we all know that panicking doesn't do anything. Panicking and buying all the toilet paper in the world doesn't prepare you for this.
That's right.
But being calm and taking 30 deep breaths, you will feel better than you did before that. Now, did you solve everything? No. But you had a positive effect. And you're halfway to those 60 breaths that you're supposed to use to make your body better every day.
That's right. That's right. Oh, man. Love the information that you shared today, Andy. If people wanted to get in touch with you, ask you more questions from the PT side, from the general public, how can they do that? How can they get in touch with you?
You can email me at andy@academywestperformance.com.
Okay.
Things are kind of crazy right now, and
Sure.
we're shut down on an outpatient basis, but I'm here full time at the hospital and working as hard as I can to try to get us ready. So I'm like I say to the nurses that are here and the docs that are here and the respiratory therapists, because what I'm doing is a little bit different than what most PTs are doing.
Yeah.
And all those people, whether it's doc, PT, nurse, RT, none of those people really own breathing. And I think it's important that educating everybody around you, like if you have some understanding about how to breathe a little bit better, share it. That's
Yeah.
why I'm talking to you. This
Yeah.
is an important thing for everybody to understand, that
Yeah.
we've all got the same tool and we all could use a little bit better breathing. Like,
Hmm.
can you find me one person that says, no, I don't want to breathe any
I don't
better?
want a better breath. No, thank you.
Yeah, you're not going to find that
You're not
person.
gonna find that.
So, if you start looking at it and start thinking about it, you will start understanding this. It's just a matter of saying, okay, I'm going to start looking. I'm going to start thinking about breathing, period. Because you
Yeah.
probably haven't. If there's a curiosity and you want to learn more, the courses by Mary Massery will change how you look at the body. And I would recommend any PT or OT or speech therapist to sign up for those at, with Mary Massery.
Yeah, and I'm looking forward, because I know you're going to be eventually having your own clinic and really focusing on breathing, Academy West Breathing and Performance. I'm really excited to see what you do in the future. But what you're doing now, I just have to thank you so much. You're on the front lines. You're doing so much for those people in Central Oregon. Thank you, and hopefully people can recognize that the work that you're doing is something that saves days of people in ICU, and the recovery time is faster. They're able to overcome quicker and get back to functional activity. I mean, you're improving people's lives faster, quicker. You're saving hospitals millions of dollars. Your work is amazing, and like you said, I hope it gets more promotion, more publicity going forward.
Well, I appreciate that. I think you're right in that it's really important work that we're doing down here. People ask me why I work in the ICU. I work here because this is where the best team is.
Mm,
There is a blurring of lines the more critical the patients get.
sure.
The PT's job and the OT's job and the
Mhm.
respiratory therapist's job and the nurse's job and the doctor's job, they all kind of blend together, and there's tons of communication, there's tons of collaboration. So I'm trying to be the best advocate I can for that team and for my patients, and trying to just do my part. My part is I want everybody in this community and everybody in this hospital to breathe better
Yeah.
and to maximize how much potential they have physically and beyond. So
Yeah.
that starts with how you breathe. It's not what I expected to be doing when I went to PT school. And I could take you down the road of how I ended up here. And it's I think it's a good story, but
It's a cool
suffice it to
story.
say, I love my job,
That's awesome.
and I'm really happy to be here doing this, even though it's such a messed up time to be
Yeah.
working in an ICU and seeing things you haven't seen
Um,
before in the volume that you haven't seen before. But
uh,
we're going to get through this just like we get through everything else.
yeah, man, I wish you luck. Good luck with everything. I mean, what is it, March 28th, 29th,
Ninth.
and 29th, and hopefully, man, there might be more coming around the corner here soon. Wish you the best. Stay on top of things. Wish you the best in Central Oregon and in your work, and stay safe and stay alive, and good luck with everything, man. I appreciate your work and your time today.
Well, I appreciate you, Nathan. I think we're probably going to peak here in about May. So we're settled in for the long haul. And you know what?
Okay.
I'll leave you with this. I think this struck me really the other day. The military has a term called VUCA. VUCA stands for volatility, uncertainty, complexity, and ambiguity. We are, without a doubt, in a time of VUCA
In the
right
middle
now.
of VUCA. That's true.
Absolutely. But with every opportunity, or excuse me, with every period of volatility, there's always opportunity.
Definitely.
I think that this period of volatility has opened an opportunity for physical therapists and rehab specifically to have an impact on our patients
Hmm.
through improving their breathing
Yeah.
and doing that on a grand scale. because
Mhm.
there's going to be a ton of PTs that need to go back to work
Yeah.
when all this settles down. And there's going to be a ton of people with respiratory issues that have no idea how to breathe and no idea how to use their bodies. And
Mhm.
nobody out there better at explaining your anatomy, your biomechanics,
Mhm.
how to use your body, and how to perform better than a
Yeah,
physical therapist.
that's right.
So
And
this is the time for
incorporate
us to
all
shine.
yeah, incorporate all of that back into everyday function and high level performance. I mean, we
Absolutely.
run the gamut.
Yeah,
That's awesome.
absolutely.
Hey, again, thank you for your time, Andy. I appreciate it.
No, my pleasure, Nation. Thank you very much.
All right, take care.
Take care.